Thank you for catching that. All right, let's try this again. So again, today's Tuesday, December 1st. We were just talking about the schedule, and we were finishing off talking about the final. And that's really the only really new thing on there anyway. So it's a good thing you caught that when we are doing that. Again, the final exam is going to be 100 questions. You're going to have 100 minutes to complete it. It's all multiple choice. None of them are multiple choice questions that have been on previous exams or previous quizzes or things along those lines. So it should be a whole new sample of questions covering everything we've covered from this class. The format of them are multiple choice questions, so that should be pretty simple and straightforward. The only thing that might be slightly different that we haven't seen from previous exams is there will be some identification multiple choice questions where you'll be given an image with some labels on them, and you have to say what A is or what B is or something along those lines. Again, those are the types of questions we would normally ask on a lab exam, but there is no lab exam, final exam, so we're incorporating it that way. The other type of question you probably haven't seen before that we'll need for this is going to involve processes. Normally a process is something you describe in an essay question. And if something has 5 steps, you need to describe all 5 of those steps. Instead, what you may see are some questions that have the 5 steps of a process listed, and your job will be to put them in order. So there'll be, 4 or 5 different options. Is it 4, 3, 2, 7, 5, or whatever it is, and you'll have to do it that way. But other than that, you should know what to expect from that. You have the whole class time to complete the final exam, or let me rephrase that. You have the entire class time to take the final exam, but you must complete it within 100 minutes once you start it. So if you wanted to wait till, 3 to start it, where you've got 95 minutes to be able to complete it at that time, you are welcome to do that. Although honestly, I would not encourage you to do that, because as you know, sometimes problems can occur during this process. Things take time to load, or you have problems loading, or you get kicked out and have to get back in. And again, if you start at 4, you're only gonna have 35 minutes to complete it. So it is better to get it done earlier. That way, if there's any problems, those problems can be resolved and we can fix it. Once we hit 4:35, the class is over and you're done with the exam at that point. So start earlier. And again, think of it the other way. The advantage of starting early is the sooner you start it, the sooner you end it, and the sooner you can start drinking. All right. The final is Tuesday the 15th from noon to 4:35. So it's during our normal class time, the same way that it would normally be. So you have the entire class time to take the final, but again, you're only going to have about 100 minutes to be able to complete the 100 multiple choice questions. It's everything based. So it includes everything that we've talked about in this class. I honestly, again, when I made the test bank of questions, I didn't break it down by lab or lecture type of material, because again, this is all one class. Lab and lecture really are just different modalities for learning this material, right? Especially true online. We don't really have a true lab online. So it's, anatomy stuff is we do the best we can with that. So I would say it covers all the material. I more broke it down based on the fact that there are 5 different sections to this class. And so there's 100-point questions. So about 20 questions for part 1, which would be the cardiovascular system, about 20 questions for part 2, the lymphatic, endocrine, immune response, right? And then digestion and things along those lines. So it's pretty close to that. All right. Some sections had a little bit more, some had a little bit less. So it may be a little fluctuation in there that way. But again, it should be a pretty even distribution over all the material we've covered in this class. All right. No group exams. All right. As a scientist, especially as an anatomist, I'm all about the glory. I want to discover something and I want to plant my flag on it and screw everybody else. So you're barking up the wrong tree with that. All right. Any other questions? All righty, then let's dive into the new material. Oh, I didn't start my lecture yet, so let's stop that. Go here. All righty. We left off last class and we had been working our way through, hold on. more thing. Make this easier. Perfect. You can hide up there. We were working our way through the anatomy of the male. We had talked about the testis. We had talked about the function of the testis. We had talked about the ductwork system. We talked about the scrotum. So the only real anatomy we have left, of course, for the male is the external genitalia, that is the penis. Of course, as we all know, it has the diameter of a soup can, is 75 inches long. It's prehensile with 14 junctions in it and can wrap around your leg and pull you down if you're dangerous, right? So again, when we talk about the anatomy of the penis, there are two distinct regions to them. There is the elongated shaft or body of it, and then there is the enlarged head, or what is known as the glans penis. This particular illustration doesn't show it, but we have another one that we'll look at in a minute, where there is an extension of the skin, the thick, hardened, keratinized skin that wraps over the sensitive end of the glans penis, known as the prepuce. And of course, what do we commonly refer to the prepuce as?
Foreskin.
Right, it's the foreskin, absolutely. For religious, for medical, for cultural reasons, the prepuce is often removed in a process called
Circumcision.
Circumcision. There you go, excellent. Perfect. So we have that anatomy there. But what we haven't talked about, again, circumcision is, like I said, there are really three main reasons why circumcision occurs. One is cultural, one is religious, and one is medical. So I think it depends a lot on the country. In some countries, it's more common than in others. Since we're in the United States, circumcision tends to be fairly common, although not being circumcised is making a bit of a comeback. So again, while there are some potentially compelling medical reasons for doing it, if maintained properly, it can be just fine to leave the prepuce. Basically, the key with the prepuce is if you have a prepuce, it must be cleaned out regularly. Otherwise, it's a major site for infections and other types of disorders that can happen again in that fashion. So most of the time it is removed medically just because it is easier. But the prepuce, if maintained properly, can be a fine structure, and it maintains better sensitivity to the glans penis when that occurs as well. So I've not heard of it necessarily closing up entirely, but I will say, as I mentioned, if not, so here's the two things that happens. It does need to be cleaned, and then it also does need to be stretched occasionally as well. The same way like your muscles, for instance, your skin needs that pliability to it. It is potentially possible that if not cleaned properly, bacteria can occur and it can actually adhere to the glands that way from a bacterial infection. The tissue itself could harden, not so much that it would close, but that it would make it harder to retract it. And so that makes it more likely with intercourse or with other type of vigorous activity that it could potentially become damaged. And if it gets torn and damaged, then typically would need to be removed surgically as well. So I'm not sure about it closing entirely, but it can lose its elasticity that way. So that could be a concern. All right, when we look internally, as we see here in the penis, there are three main regions containing a special spongy erectile tissue that is what turns the penis into the copulatory organ that it is. And we'll talk about the function of that in a moment. Here we see kind of a longitudinal view through it. And we can see a couple things here. Let me use my highlighter for this. Notice here, they've got a representation of the prepuce, that fold of the skin that wraps around it. And notice here, we get a better view of the internal anatomy. As we mentioned, there are 1, to three separate regions of this erectile tissue that, again, is going to enlarge the penis and give it its rigidity to make it that copulatory organ. The internal erectile tissue, spongy tissue, is known as the corpus spongiosum. And you will notice that it is what enlarges distally to become that apparent glans, that enlarged head of the penis that we see. But you'll also notice that it enlarges proximally as well, forming a structure called the bulb, where it helps to anchor itself to the pubic symphysis and to the urogenital diaphragm. Notice this is also where the bulbourethral glands that we talked about, right? Remember we talked about how they release their secretions, that pre-ejaculate into the urethra. And as you can see, its duct goes through the bulb of the penis, which is where it gets its name, bulbourethral gland. Right? But like I said, you can also call it the Cowper's gland because that is what it is called, and Cowper is easier to spell. Here we see it in a cross section, and so we again see the three areas of erectile tissue, but we also see the relationship to them as well. Let's go back. We were talking about it. The corpus spongiosum, remember, has the two enlargements, the bulb and the glands. And as you can also see from this illustration and from on the next page, it surrounds the urethra. Why might it be important to have erectile tissue that surrounds the urethra? This is anatomy and physiology. We're allowed to talk about these types of things. Why do you think that it is important to have erectile tissue around the urethra? Well, absolutely. The point of copulation is to fertilize the female, propagate the species, and we need semen to be able to pass through the urethra. So we need to keep the urethra open, right? Copulation, when done properly, should be vigorous. And if that vigorous activity of copulation causes the urethra to collapse, are you going to be able to release the ejaculate? Are you going to be able to fertilize the female? No. So it helps to maintain the integrity of the urethra so that ejaculation can occur. So as we said, it forms the glands and it forms the bulb proximally. Notice there are two much larger erectile tissue structures known as the Corpora cavernosa. That is, of course, the plural. Corpus cavernosum would be the singular. Hold on, there's a... Babies don't feel pain. I'm not sure I buy that. I mean, again, I'm not suggesting anybody go around and poke a baby with a pin to see if, they respond to it. What I would say is that the neural network is very incomplete. So there's probably a lot of spontaneous activity. So they're probably not quite as aware of stimuli that way. But maybe. So I wouldn't say that, yeah. I wouldn't say it's so much that, well, see, the other issue is, like, for instance, can they perceive light, right? Can they see? Well, certainly they perceive light, but can they understand and make sense of what they're seeing? No. So my guess is that neural activity would be sent that normally you and I would perceive as pain, and I'm not sure that the baby would be able to interpret it in that fashion. But my guess is that it probably isn't something enjoyable. That's a great question. My guess is that they might not interpret it that way. So hopefully that would be the case. I mean, because you could argue that birth is an incredibly vigorous and potentially damaging process. That could cause a lot of injury. So sure, I'll buy that. I wouldn't say necessarily that they don't feel pain, but because that makes it things like no neurons, no action potentials are fired. I believe action potentials are fired. They probably just don't have the neural network to interpret it as a painful stimulus is the same way. Not sure what the sugar water is supposed to do. Interesting. Oh, I see. Okay, I thought you meant like they put the sugar water on the penis, so I didn't get that. Okay. What is it, making it hypertonic to try to draw the water out of it? I was like, what is the purpose of that? Okay, that makes way more sense. All righty. Notice with these Corpora cavernosa, they don't have the urethra pass through it. They're large structures. And again, their job is to give the penis the rigidity necessary to be able to penetrate the vagina and participate in copulation. Notice a couple things about that, right? Because if you think about it, it's called a spongy erectile tissue. But when you take the kitchen sponge and you put it in the water, it absorbs that water and it expands. But does the sponge become rigid as a result of that? No. The reason for that is here, the other structure that you will see here in the Corpora cavernosa is that spongy erectile tissue is surrounded by a collagenous fiber mesh. So what happens is, as that tissue expands, it pushes against that collagen fiber skeleton. And as it pushes against that fibrous skeleton, the collagenous fibrous skeleton, that swelling against it is what causes it to become turgid and causes it to become rigid. As you can see from the previous picture, the Corpora cavernosa are superior and lateral to the Corpus Spongiosum. And again, hopefully you guys did all your homework of seeing the function of the cremaster muscle, seeing the function of, or identifying the raphe, palpating the ureter and all of that. And if you do that to a male, it is quite possible he may become turgid as a result of that. And if you are daring enough to palpate the penis, you can actually feel those three distinct erectile tissue structures. So you can actually individually palpate and distinguish those structures in the shaft of the penis. So they're located superior and lateral to the Corpus Spongiosum. Notice at the proximal end, the Corpora cavernosa taper. And as it tapers, it forms a structure called a crus, the singular, the plural being the crua. And the two crua plus the bulb together form what we call the root. So these three structures together help to anchor the penis to the pubic arch, to the urogenital diaphragm, and form what we call the root of the penis. All right. Questions on that anatomy, and we'll look at this histologically as well and see more of that that fibrous skeleton around it and those structures as well. I guess we should say it here. That fibrous skeleton around it is around the corpus cavernosum is known as the Tunica Albigenia. Right? Again, it's the white layer, white tunic. So we saw that on the testis. We're going to see it on the ovary. Here we see it on the Corpus Spongiosum as well, or Corpus Cavernosum, I should say, as well. All right, questions on that? All right, now that we know what the penis looks like and the glands look like, let's talk about how these things work. Again, the goal is copulation, the goal is fertilization. So that involves two processes, erection and ejaculation. These are, of course, autonomic reflexes, right? You cannot consciously cause the penis to rise or lower. So these are autonomic reflexes. And a good way to remember them is point and shoot, right? Point, the arousal, the erection, is a parasympathetic reflex. And shoot, the orgasm or ejaculation, is a sympathetic reflex. So if you remember point and shoot, you can remember the function of the penis. Let's talk first about arousal, or the erection, or the state of tumescence. as I mentioned, becoming tumescent is a parasympathetic reflex. When a male is aroused from you observing his Raffy or any other things, watching Game of Thrones or whatever it is that gets him going, that arousal by the parasympathetic nervous system causes the release of nitric oxide. Remember, one of the things that we talked about previously is that most blood vessels are controlled by the sympathetic nervous system. But remember, the key word there is most. Most is not all. There are a few that are controlled by the parasympathetic, and primarily those are the ones that control this erectile tissue. So here in the erectile tissue, our parasympathetic nervous system causes the release of nitric oxide. And as we know, nitric oxide causes the smooth muscle of our blood vessels to relax. The arteries, they relax, and it causes that vasodilation. That vasodilation brings more blood to the erectile tissue. And it engorges with blood, causing it to swell. However, as we mentioned, not only does it swell, but it becomes rigid because it pushes against that collagen fibers that stabilize the structure and cause it to become turgid or rigid. At the same time, we have the expansion of the erectile tissue. What ends up happening is that expansion of the erectile tissue compresses the veins that drain the erectile tissue. This causes the structure to become congested with blood. Right? Normally, we don't think of this congestion as a good thing when an area becomes congested with blood. But, right, when done properly, how long should intercourse take? Right, there you go. 30 seconds to a minute, exactly, when done properly. It's a relatively short period of time. So when it becomes congested with blood, yes, that's not necessarily the best for the tissue, but intercourse typically doesn't last a long period of time. Erection doesn't last for a relative long period of time. And so as a result, it's not an issue. However, anytime you watch these TV commercials, watch a football game, and they talk about little blue pills or things like that, what's the warning they always give? Come on, I know some of you have watched football before. Right, if you have an erection that lasts more than 4 hours, go see a doctor immediately. Because if that area stays congested with blood for a prolonged period of time, that tissue starts to get deprived of oxygen and can become necrotic and can die. Right? And as we've talked about, when tissues die, there are two ways to repair it: regeneration or fibrosis. And erectile tissue heals via fibrosis, which means the damaged tissue is replaced by scar tissue. And is scar tissue going to swell and inflame and enlarge in the same way that the erectile tissue does? No, and so it can lead to a loss of function, a disfigurement of the penis, and a loss of an ability for copulation, right? This is the same issue with, and I hate to use the term toy, but there is a sexual device that is basically a ring that can be placed at the base of the penis. The goal of this ring is to do the same thing: constrict the blood vessels so the blood doesn't drain. This allows the male, right, yeah, penis ring, I was going to use a different word for it, but yes, penis ring works as well. Allows the penis to become engorged with blood for a longer period of time, possibly getting more blood in it, right? Giving you the bigger, stronger erection as a result of it. The problem is these things aren't one size fit all. And if it is on too restrictively, then even when intercourse ends, then as a result of that, it may not drain properly, and it can actually get stuck, and it can become congested, and the tissue can become necrotic. And of course, you have to get rushed to the hospital. And how do they resolve it? Do they get the jaws of life to cut that ring off of the penis? No, but what they will do is they will stick a very large bore needle into the penis to suck out some of the blood, decreasing the penis's size so that the ring can be taken off. You have to deal with the potential of the necrotic tissue from the congestion of blood. You have to deal with potential scar tissue from the needle that was being placed in there, which again can dramatically infect the function of the penis, all because of a toy, right? So don't do that. If the area became congested long enough, you could potentially constrict blood flow to the skin of the penis, the distal tip of the penis, and that could cause a numbing sensation. So that could cause problems that way as well. It's primarily the rectile tissue that it affects the blood flow of, because it's not going to stop the smaller superficial blood vessels that are going in there. But I could see where potentially it might cause some kind of nerve issue if it was left on for, or medically you had an erection that lasted for a prolonged period of time. All right. Now, remember, arousal is also not just about the rigidity of the penis. There is also glandular activity as well. So again, when a man becomes aroused, two events occur, really three events occur. We have change in smooth muscle activity. We have increase in blood flow to the area, and we have glandular secretions. And I make a point of emphasizing this because these three same things occur in the arousal of a female as well. Remember, the bulbourethral glands produce that pre-ejaculate that we talked about. It is thick, it is viscous, it is clear, mucousy. And its job, remember, is to neutralize the acidity of the urethra and to act as neutralize the acidity and produce lubrication for insertion into the vagina. All right. Now, remember, as we talked about, we also get smooth muscle contractions. And in this case, those smooth muscle contractions would take place, remember, in the ampulla of the ductus deferens. So remember, as we talked about, some spermatozoa will be released in that pre-ejaculate as well. And I believe, if I remember correctly, we have someone who's proof positive of that fact that you can get pregnant even when trying to do the withdrawal method because of that pre-ejaculate. All right. Questions on arousal? All right. Done silences mean we understand, move forward. So let's get to ejaculation. Ejaculation, oh wait, hold on, here's a question. I'm not sure that there is a normal. I don't know what the average time of intercourse is. I think I've read somewhere that it was 3 hours. I mean, obviously, there are a lot of factors that can influence that. Primarily, the sympathetic and parasympathetic input. As we've talked about before, one of the things that can happen with a male if he is nervous is that sympathetic nervous system can override the parasympathetic, influencing and affecting the ability for the arousal to occur. And then once aroused, we start this process of a positive feedback reflex, positive feedback reflex arc, where you are going to get the stimulation that comes to it. I would say that I'm not sure. Again, I've never done I've never looked at it. I don't know what the average is. I think they have a vague recollection of maybe it's somewhere like 3 minutes or something like that. But obviously, there are many factors that can influence it. Everything from the position the amount of lubrication, the speed, all of those things, because they all influence the stimulation. Basically, what happens with the male is as the male's penis is stimulated, that stimulation basically increases the sympathetic output, which causes more stimulation, which increases the stimulation, and eventually you reach that critical point where ejaculation is going to occur. So there are many factors that can influence how rapidly they reach that critical point. Again, some could be the vigorousness, some could be the amount of lubrication, things along those lines. But again, just like in females, a lot of it is also mental as well, right? The more aroused a male is by the situation or the environment or the location or the props or the clothing that are being worn. And also, as we'll talk about with males, there's also a refractory period. Right, so how frequently the male ejaculates on average, how recently the last ejaculation was, all of these are factors that can influence it. So I wouldn't say that there is just one time, set time, right? that it's not like a, an egg timer, you turn it on and when it hits ding, then it goes. There are many factors that can influence it. Smooth muscle contractions, glandular secretions, and engorgement of blood, of erectile tissue. So those are the three factors that will occur in both males and females. And we'll talk about female arousal and an orgasm as well. So, like I said, ejaculation is a sympathetic positive feedback reflex, where again, that arousal increases the sympathetic stimulation, which causes more arousal, more stimulation, and more until eventually some critical point is reached. And once that critical point is reached, then again, we have two main events that are going to occur: smooth muscle contractions, glandular secretions. So muscle contractions occur. First, the contract of the internal urethral sphincter. Why would we want to contract the internal urethral sphincter upon orgasm, upon ejaculation? Okay, some of it could be higher pressure. Certainly, we don't want urine to be released. That is definitely one of them. And in fact, it is impossible to urinate and ejaculate at the same time. But there's another reason why we want to close that as well. Not only do we want urine coming out, but what else don't we want? Yeah, well, we never want bacteria in there. Wrong pathway for feces. We don't want semen going in, exactly, right? The goal is to close off the possible pathways for the semen, right? There is a medical condition. I used to know the name of it. I was actually, when we were thinking about the start of lecture today, I forgot, I didn't have time to look it up because I've forgotten. There is a medical condition where the internal urethral sphincter does not close. And so what happens is when the male ejaculates, the ejaculate actually goes up into the bladder instead of coming out the end of the penis. Obviously, if that occurs, it's impossible to fertilize the female when that occurs. That is something I believe can be resolved surgically, but like I said, I forgot to look up the name of it. But yes, the goal is to ensure that the ejaculate is released out the penis into the female. So we're going to get that contraction of the internal urethral sphincter. So it's really about making sure the semen goes the right way. But the fact that urine doesn't come out is nice for the female as well. Smooth muscle contractions will lead to the release of the secretions from the seminiferous seminal vesicles, from the prostate, and in the ampulla, releasing the sperm as well. We will then get peristaltic contractions of the urethra, which will expulse the ejaculate in a pulsatile nature out of the penis, again, hopefully into the vaginal canal. Once ejaculation occurs for the male, then the male enters basically a refractory period that we call detumescence. Again, this detumescence is also driven by the sympathetic nervous system. The other smooth muscle that contracts is the blood vessels of the erectile tissue. Obviously, if you constrict the blood vessels of the erectile tissue, that is going to decrease blood flow to the erectile tissue. But also in that in that tunica albicans, there is also smooth muscle, and that smooth muscle will constrict the erectile tissue. And when this occurs, this basically forces open the drainage veins, and the blood drains from the erectile tissue, and the rigidity of the penis is lost. Now, we were just talking about timing again. All males have a refractory period, this period of detumescence, but will every male have the exact same detumescence period of time? No, it can vary from minutes to hours. And it is typically one of those things that increases with age. The detumescence period typically increases with age, so that, grandpa basically, is good once a week. Okay, probably not that extreme, but you get the idea. All right. Questions on that? All right, there you go. So the last thing we need to talk about are the hormone cycles and regulation of process in males. And the good news is this is an incredibly basic and simple process. Boys are pretty basic and pretty simple. Let's start with the onset. Androgens, primarily testosterone, is produced by what cells? What cells produce our androgens? Interstitial cells, excellent, in the testis. What is the hormone that regulates that production?
Follicle stimulating hormone.
Is it follicle stimulating hormone that causes the production of androgens?
Luteinizing.
Well, okay, so now I've heard both. Which one is the correct answer? Luteinizing hormone or follicle stimulating hormone? Someone pick one. Luteinizing hormone. Excellent. It is indeed luteinizing hormone that causes the regulation of the process of androgen production in our, oops, there we go. I guess I did write that there. Perfect. Androgens, remember, as we talked about, lead to the maturation of sperm. They do not influence, sperm production, right? It just influences sperm maturation. And where does that sperm maturation take place again? There we go. The epididymis. Perfect. And as we know, our androgens maintain and mature. All right, so they cause the maturation of the reproductive organs, they maintain the reproductive organs, increase metabolism and growth, as we talked about, especially muscle and cartilage. And I can spell cartilage. Muscle and cartilage. All right, all those secondary sexual characteristics like secondary hairs, right? Thickening of the vocal cords, making the deeper voice, enlarging the Adam's apple, all of those types of things as well. And of course, our sex drive and aggression, right? No new information there. We've talked about that already. And again, this primarily occurs when or starts when? Puberty. And continues till, when does it end? There you go, pretty much death. Right, exactly, 15 minutes after they're dead, exactly. So it is a fairly consistent process. Now, that doesn't mean that there aren't fluctuations. Males do actually have a hormone cycle. However, their hormone cycle is more daily as opposed to monthly, the way that a female's are. Typically, hormone levels are slightly higher at the beginning of the day and slightly lower at the end of the day. But the fluctuations are incredibly minor compared to what we see in a female. As we also talked about, it can decrease with age, but it doesn't have to, right? So it can continue to stay at a relatively high level, basically all the way to death. So as we talked about, basically we are able to produce, that's actually a great question. Let me answer that in a second. From puberty to death, and again, it can't, which allows people to have offspring at a very, very old age compared to what females are capable of doing. There have actually, interestingly, a fair number of studies looked at this phenomenon known as morning wood, where a male gets an arousal upon awakening. And there are basically two main thoughts as to what the cause of that can be. What they believe primarily it is involving is that as we sleep, obviously the blood is continued to be filtered by our kidneys, and we continue to make urine, and that urine is continually released into our bladder. So for both males and females, one of the primary things that a person has to do first thing when they wake up in the morning is go to the bathroom. It is believed that the enlargement of the bladder may push pressure on the nerves associated with arousal, and that may stimulate the nerves and cause the erection to occur. The other thought is that it may play a role, it may be involved instead in the waking and sleeping cycle. Upon waking, typically you get an increase in blood flow, an increase in autonomic tone in the body, and that increase in autonomic tone may be what causes the arousal to occur. So those are the two current theories that I'm aware of. But again, I don't think anything has been definitively determined, but those are the current theorems as to what may possibly be happening with that. So it doesn't appear to be related to the increase in hormone levels. Although again, if you think about it, that makes sense, since we do know that androgens affect sex drive. So higher androgens levels might lead to a more likelihood of having an arousal upon awakening in the morning. But I don't believe that that is one of the theories that is being currently looked at. As you can see here, it is a fairly consistent process, right? And actually, I like this picture, but let's go ahead and draw this for ourselves. All right, we know the players in the game. Nope. Yes, Alex, you may tell her that. Of course, you realize that doesn't mean you weren't dreaming about other women, but that's beside the point. All right. This, of course, is our hypothalamus. This is, of course, our anterior pituitary. As we know, our hypothalamus produces gonadotropin, releasing hormones. Those gonadotropin releasing hormones, as we know, whoa, not sure what just happened there, stimulate the anterior pituitary and cause the anterior pituitary to produce two hormones, the gonadotropins. And what are the two hormones that are produced by the anterior pituitary again? There we go. Follicle stimulating hormone and luteinizing hormone. And I'll go ahead and use the abbreviations here as well, just because it'll be easier. So our anterior pituitary releases our luteinizing hormone, releases our follicle stimulating hormone. And let's follow the path. As we just finished mentioning, what is it that the luteinizing hormone stimulates? What is its target? Bingo. Interstitial cells. Interstitial cells, and you guys are absolutely correct. The function of this interstitial cell is to produce androgens. Excellent. Oh, and sorry, the OCD in me is wanting that. Excellent. And be careful here. What does our follicle stimulating hormone stimulate? What is the target of our follicle stimulating hormone? Ah, excellent. Nerve cells. And it stimulates that nerve cell to basically do two things. One of the things this nerve cell does is what? What are the things that nerve cells do? True, it does indeed produce androgen binding proteins. Excellent. What else does it do? There we go. Again, careful, not the maturation of sperm, but nerve cells actually drive the production of sperm. They cause the sperm to be produced in the seminiferous tubule. Basically, they drive the division of the spermatogonium and the maturation of the primary spermatocytes. They drive meiosis and mitosis. So they drive the production of the sperm. But there's one other important thing for this process that our nerve cell does. I don't remember what the other thing the nerve cell does is. The nerve cell remembers what is responsible for producing inhibin. You're right. It does phagocytose the cytoplasm of the spermatids as they are undergoing spermiogenesis. But I think that would fall under the production of sperm. The other thing our nerve cell does is produce inhibin. All right. So these are our linear processes. Hypothalamus produces gonadotropin releasing hormones. telling the anterior pituitary to produce luteinizing hormone. And that luteinizing hormone tells the interstitial cells to make androgens. Anterior pituitary gonadotropin releasing hormones tells the anterior pituitary to release follicle stimulating hormone. That stimulates the nerve cells. The nerve cells then release chemical signals that drive the production of sperm, cause sperm to be made. Tells the nerve cells to make androgen binding proteins, but it also causes the nerve cells to produce inhibin. Now, as we talked about, male has to make 500 million sperm during the course of the day. So on the surface, it might think more is better. More gonadotropin releasing hormone, more luteinizing hormone, follicle stimulating hormone, more sperm, more testosterone, more. Yeah, it'd be tiring, but more has got to be better, right? But remember, as we talked about, that's not the case. We want to control the production process so that the sperm, we're not just producing sperm, but we're producing it viably. We don't want to just have as much androgens as possible in the body, right? Anybody who's ever seen someone undergo a roid rage at a gym knows that that isn't necessarily a good thing. We want to keep tight controls on these things. And so there are two feedback processes that control this and regulate the tempo at which this occurs. The first of those involves the androgens. Androgens, so let's do this one first. We'll do red. We'll do this here. Levels of androgens in the blood drive a, let's say it this way. Levels of androgens in the blood are regulated or monitored by the anterior pituitary and the hypothalamus. And if the levels go up, we decrease production. Of gonadotropin releasing hormone and of our gonadotropins. What type of regulation would we call this? Where we have chemoreceptors. Oops, hold on. Where androgen levels are going to monitor that. This is it. Well, negative feedback, remember, would be if the interstitial cells were monitoring the levels of androgens. And if the androgen levels went up, our interstitial cells said, oh, there's too much of it. Let's bring it back down. Oh, there's not enough of it. Let's bring it back up. Our interstitial cells don't get to decide how much androgens it makes. It is told how many androgens to make by the anterior pituitary. The anterior pituitary releases luteinizing hormone and tells the interstitial cells what to do. What we have here is the hypothalamus and the anterior pituitary are being controlled, are being told, let me say it this way, are deciding what to do based on the amount of androgens that are in the blood. What does that sound like? What type of regulation is that? Exactly. This is humoral control. Here it is the amount, the number, right, of the androgens in the blood that determine how much hormones it produces. Conversely, on the other side, here, our nurse cell is producing inhibin. So more follicle stimulating hormone equals more inhibin. Inhibin, remember, is a hormone. And what is the target of inhibin? Yeah, it's going to target the anterior pituitary. And it can also influence the hypothalamus as well. It targets those, and what does it tell them to do? Yeah. It basically inhibits production and release of the hormones. What kind of control would that be? What type of regulation is this? Exactly. Hormonal control. I know the red one here, androgens, is tricky because it is a hormone. But remember, it's not the hormone affecting the hypothalamus and the anterior pituitary. The hypothalamus and anterior pituitary are counting how much of that hormone is there. Whereas inhibin is the hormone that targets and influences these cells. So with inhibin is expressing hormonal control, where androgen levels are controlled humorally. So notice how this works. It keeps things stable. If too much follicle stimulating hormone is being released, we produce more inhibin, and that tells the anterior pituitary to release less follicle stimulating hormone. And that slows sperm production down. If there's not enough follicle stimulating hormone, the nurse cell produces very little inhibin, and with only a little bit of inhibin, it's not inhibiting the anterior pituitary, and it can release more follicle stimulating hormone. All right, so both of these, the goal of these processes, very simply, is to maintain standard levels. You don't want to be producing too many sperm, don't want to be producing too few. Don't want to be producing too many androgens, don't want to be producing too few. We want to maintain consistent, stable levels of androgen production and sperm production. And the male hormonal cycle, the male control, regulation of male reproductive functions is really just that simple. I'll give you a hint. Females aren't, but males are. Right? So again, we have this, again, it's a negative feedback process the more there is, but really it's providing that humoral control. Whereas inhibin is providing that, hormonal control. And there's this picture, but I like this one a little bit better. Here we go. Here we see this nice flow chart. Again, androgens with that level, providing that humoral control, how much of it, counting how much is there. We get that negative feedback via humoral control, whereas inhibin, we get that hormonal control. And just that simply, we are done with the boys. All right, now that we understand how the Volkswagen bug works, we get to try to work our way up to the Lexus. And again, we'll do the best we can with this. Obviously, there are entire semester-long classes you can take on reproduction and development. So obviously, we're not going to be doing great service to this, but we will at least cover it well enough so that we can have a basic understanding. All right, so anything on the boys before we finish up? And this is a good spot to take our first break. So any questions before we finish up the boys and move on to the women? Excellent. All right. Oh, wait, hold on. Yes. So yes. Thank you. Thank you. That was the other thing that I meant to do today. Yes. Talk about the exams. I wanted to talk about the exams as well. You guys did pretty well. The lab exams I was very pleased with. You guys did really, really well on that. I know there was a lot of physiology on this one, but you guys didn't do poorly, but didn't do as well as you did on the previous one, which I guess isn't terribly surprising because there was a lot of physiological processes in both the urinary system and the respiratory system. But some of those questions are things that I guaranteed you guys were going to be on the exam, and yet still some people struggled with. So you do have to really, again, at this point, being the sophisticated students you are, you should be able to come up with some ideas of what the material you're going to be responsible for and how to cover that. But yes, the grades have been released, and I will. Yep. So I will be releasing the exams this afternoon so that you'll have a chance to review it. And then if you have any questions, then obviously I have office hours tomorrow, or you can reach me by email for that. So yes, I will be releasing the exams today. All right. Great question. Any others? All right, let's go ahead and take our first break. Looks like it's 1:06, so that means let's come back at 1:21, and I will start the recording at that point. On myself so I don't forget again. All righty, see you guys in 15 minutes. All righty, let's go ahead and get started. Like I said, we have done the boys. Now let's move on to the female reproductive system. Again, at its core, it is basically has the same components and parts to it. We have the gonads. In this case, it is the internal ovaries. We have a series of connected tubes forming the duct system, including the uterine tubes, the uterus, and the vagina. However, remember, as we talked about, this ductwork system is an open ductwork system, meaning that it is open to the abdominal pelvic cavity. So unlike the sperm, when the sperm are produced, they have no choice but to go into the epididymis, no choice but to go into the ductus deferens, and on down the path. We hope that the egg gets into the uterine tube when it is released from the ovary, but it doesn't always happen. And then, of course, like the males, we have external genitalia as well. All right, same way we started with the testes, let's start with the ovaries. They're the primary female reproductive organ, and as we've already talked about, we know that it is going to produce not one, but two classes of hormones, as well as the maturation of the egg. Their location is inside the abdominal pelvic cavity, and they are lateral to the uterus. They are held in place by a structure that is known as the broad ligament. This broad ligament is an extension of the peritoneum, basically comes off the walls of the abdominal pelvic cavity, similar to a mesentery, where it stabilizes blood vessels and other structures along nerves, things along those lines as well. And basically what it does is it does divide the inferior part of the abdominal pelvic cavity into two distinct regions, or what are known as pouches. These include the suspensory ligament, which anchors the ovaries laterally, the mesovarium, which anchors the ovary from the uterine tube, which drapes over the top of it, and then the mesometrium, which is between the ovary and the uterus. Lastly, the ovaries are anchored to the uterus itself by a ligament known as the ovarian ligament. And the uterus needs to be held in place as well, and that is the job of the round ligament, which anchors the uterus anteriorly. Notice it is ligaments that hold all of these things in place, not cartilage, not bone, not any kind of big structures like that, because we need tremendous flexibility in the female's abdominal pelvic cavity, right? That uterus, which in a female who has never been pregnant before, is about the size and shape of a pear. It needs to be able to expand to accommodate basically a basketball as that baby grows inside of her. And so we need the flexibility of movement of these structures as the uterus expands for them to be pushed out of the way. Here we have it with all the pretty words. Let's take a look at the pretty picture. Here we see the pretty picture where it kind of looks a little moose-like. We have the head of the moose and we have the antlers coming and dangling down. Notice here, again, we have that ductwork system, the vagina, the uterus, and the uterine tube. The uterine tube drapes over the ovary, but is not directly connected to it. And here we see, again, notice this is a posterior view we are looking at. That round ligament extends anteriorly to help to anchor the uterus in place, while there is this round ligament, this large ligament known as the ovarian ligament that helps to anchor the ovary to the uterus. Here we see the structure that is collectively known as the broad ligament. Notice this broad ligament is this big, huge expanse of the parietal peritoneum, stabilizing blood vessels, stabilizing nerves, stabilizing the ureter that comes off the back wall. It is anchored to the lateral wall by the suspensory ligament, and it is formed primarily by the mesometrium, which, as we talked about, basically connects the ovary to the uterus this way. And then here, between the uterine tube and the ovary, is our mesovarium. So we have our mesovarium above, between the uterus and the uterine tubes, mesometrium below it, and collectively they make the broad ligament. And then we have those additional ovarian ligaments and round ligaments that stably but flexibly holds all of this in place. If we turn this and look at a sagittal view, we see the relative location of the female reproductive tract. Notice the female reproductive tract is posterior to the bladder and the urethra, but it is anterior to the rectum and the anus. So again, for the female, the urinary system and the reproductive system have separate openings, whereas as we talked about in the male, they share an opening. Notice also that between the uterus sticking out and the broad ligament held in place by the suspensory ligament, basically the inferior part of the abdominal pelvic cavity, the inferior part of the peritoneal cavity, is divided into two pouches. One of those pouches is the vesicouterine pouch. This is the anterior pouch. And then the posterior one between the uterus and the rectum is the rectouterine pouch. So we have these two indentations. And again, the whole purpose of all of this is to allow for the expansion to accommodate that basketball that has to grow inside. All right, questions on that? All righty, let's talk about the ovary. Like the testis, it isn't much to look at anatomically. Relatively small in size, about 2 inches by 1 inch in diameter, and it only weighs about 1/4 of an ounce. It is relatively small, but it is incredibly powerful in its functions. Here we actually have a cat's ovary. This is actually a cat's ovary that has been stimulated hormonally to mature many of the follicles that we have inside of this, and we'll see the importance of them and their role in the function. Like the testis, there are two external layers on the outer surface. The first is what is known as the germinal epithelium. The germinal epithelium is basically the exact same thing that the visceral layer of the tunica vaginalis is in the male. Basically, it's an extension of the peritoneum. The only difference is the testis is outside the body, the ovary is inside the body. So basically, this is a layer of the visceral peritoneum, and we could also call it a visceral peritoneum on the outer surface. But because this visceral peritoneum is specifically on the ovary, it is also known as the germinal epithelium because this is where the eggs are germinated and released through. Right? An egg that has to be released has to pass through this germinal epithelium. We'll talk about the process of ovulation and how that occurs a little bit later. But like other peritoneal membranes, it can be innervated. And there are some individual women who can actually feel the tearing of this germinal epithelium as the egg is released. It's a great German word for it. They call it middle spurts, where a woman can actually be aware of her ovulation when it occurs. Many women are aware of it, experience it their whole life. Okay, not many, but there are women who are aware, who can experience this, but they're not aware of what it is that they're actually feeling. Just every once in a while, they get a pinch in their side, not really sure what it is, but then they wave it off and they move on with their life. When I was teaching part-time, I spent a year and change at Woodland Community College. And one of the instructors there was trying to get pregnant. And she was in her early 30s. And it wasn't until her and her husband were actually actively trying to get pregnant, and she was actually monitoring her cycle, that she was actually able to realize that, oh my God, that pinch that I felt in my side every once in a while was the ovulation, that she's actually able to feel when her ovulation occurs. And not surprisingly, if you know when you ovulate, that makes getting pregnant really easy. And as soon as she figured that out, they got pregnant a month or two later. So they had success because of that. So again, it's not that uncommon. So, and like I said, there are many women who experience it aren't even aware of what it is that they're feeling. It really isn't until you're actively trying to get pregnant and you're more aware of it that you think about what it is. I mean, you think about during the course of the day, how many times you get, a pain in your knee or your elbow pops or any number of other things that happen, especially as you start to get old, you probably don't even give it a second thought. It is until you're actively aware of it that you may actually be aware of what's actually happening to you. Inside of that germinal epithelium, once again, we have a fibrous white connective tissue that forms the bulk of the structure, again, just like the testis. That is called the Tunica Albigenia. Now, unlike the testis, remember in the testis, and we'll cheat and pretend this is a testis. Remember with the testis, there are folds of that Tunica Albigenia that penetrate deep into the testis, separating it into those individual lobules. We do not have lobules here in the ovary, but we do have some general areas. And the illustration does a nice job of showing this. We have a chewy nougat center and a candy-coated outer shell. And this is definitely an organization we've seen before. And when we do that, what do we call the outer layer? Cortex. And what do we call the inner region? Medulla, excellent. So our ovary does indeed have a medulla and a cortex. However, unlike, for instance, the adrenal gland or the kidney, where we have very distinct borders between the cortex and the medulla. Here, it is more general. There isn't a definitive border to these regions. There's just two different areas that are composed of two different types of tissues and have two different types of structures in them. And here we see the same thing in a real ovary as well. So here is a simpler illustration, but again, it does a nice job of showing us these distinct regions. We have the inner region, and I'll use my highlighter this time. The inner region is basically the central portion of it. And that, oops, took that too far. The inner region is primarily the area where we have the large blood vessels and the large nerves that come into and out of the ovary. The cortex, on the other hand, is the outer region that contains structures we call our follicles. Ovarian follicles are defined as our immature egg and the support cells that help it. Now, as we can see from this simple illustration, that follicle is going to undergo some major changes during the female cycle. But whether it is a single cell with a single layer of support cells or a massive structure made up by thousands of cells and that single egg, it is still considered a follicle. But as we'll see, that follicle has many stages to it. This is where we are maturing the gametes. But again, be careful. These are not mature gametes. This is where we mature the gametes. Let's say it that way. We mature the gametes during these follicles. The follicles themselves do not contain mature eggs. As we talked about, it has an immature egg, and of course that immature egg is going to have a name. We call it an oocyte. What was the name of the immature sperm again?
Spermatocyte.
Mm-hmm. Remember, spermatocytes have stages, primary, secondary, and we're going to see the same thing with our oocyte as well. The support cells that we talked about basically come in, well, really three flavors, but there are two types of cells. They are follicle cells, granulosa cells, and thecal cells. Now, first things first, let's draw an egg. There is our oocyte. That oocyte is going to be surrounded by a single layer of squamous cells. These single layer of squamous cells are known as follicle cells. As our follicle matures, whoops, these follicle cells enlarge and become cuboidal in shape. And this, I'm doing a horrible job of drawing this, but you get the idea. It's going to be surrounded by, instead of flat cells, it's going to be surrounded by cube-shaped cells. These cube-shaped cells are the cells that now are capable of producing hormones. And in particular, what hormone class do you think are produced by these granulosa cells? Estrogens, excellent. These granulosa cells produce estrogens. So notice a follicular cell is just an immature granulosum cell. All right? But as these granulosa cells form, then what ends up happening is an additional layer of cells from the connective tissue form on the outer surface. These are not granulosa cells. These are not follicular cells. These are a different type of cell called a thecal cell. These form from the connective tissue that surrounds the follicle. And does anybody by any chance remember what our thecal cells do? Excellent. They produce androgens. Remember, the thecal cells are what produce androgens, and then the granulosa cells, they really convert androgens into estrogens. So that's really what our granulosa cells do. They take those androgens and they convert them into estrogens. So as we develop these follicles, we're basically going to have three types of cells that form around them. But notice two of those three types, the follicular cells and the granulosa cells, are just the same cells at different stages of its life. Follicle cells are a single layer of immature cells. Whereas granulosa cells can be one or more layers of mature cells. And then thecal cells are their own type. All right, questions on that? Guys always make me nervous when nobody talks a lot. I always worry that my microphone's not on. All right. Perfect, excellent. So we now know where the gametes are going to mature. What we need to do now is talk about the process of oogenesis. We already talked about spermatogenesis, and we talked about that process. The good news is oogenesis, just like spermatogenesis, involves mitosis and meiosis. Do we understand the processes of mitosis? Do we understand the processes of meiosis? Yeah, so we don't have to worry about going over those again. We understand the basic concepts of those two. So instead, we can focus specifically on how these processes occur in females. And if you think about it, spermatogenesis had three phases: mitosis, meiosis, and spermiogenesis. Mitosis, where we divide one cell into two identical cells. Meiosis, one cell into four non-identical cells. And then we change the shape of those from cell-shaped cells to sperm-shaped cells. Are we going to have three steps in the female process? Mitosis, meiosis, and oogenesis or something like that? No, it's just going to be mitosis and meiosis. Trust me, just those by themselves are going to be complicated enough. So this process of oogenesis basically involves the growth and development of the oocyte and the follicular cells that surround it. Now, one of the big differences between males and females is, remember, in males, this process begins at puberty. But that is not the same case with females. Females, being the go-getters that they are, actually start the process of working on the grandkids while they're still in utero. So let's switch to our whiteboard and work our way through oogenesis. I think I saved this already, but I'll go ahead and save it again just in case. So oogenesis. Oops. This process begins prior to birth. And it begins prior to birth with the process of mitosis. Mitosis, again, remember, is where one cell divides to produce two identical cells. Identical to each other and identical to the original one. Of course, to do that, we need a stem cell as our starting point. And what was the stem cell in the male process?
Hematogonia.
Guess what it is in the female process?
Oogonia.
There you go, oogonium. Exactly. Oogonia would be plural, that's fine. Oogonium would be singular, so exactly, both of those are correct. That oogonium divides mitotically and produces new cells. In fact, it produces millions of cells. By the end of birth, it produces about, by the time of birth, those oogonium divide to produce about 2 million cells. Now, let's start right there. Does that sound like a lot of gametes to be producing?
Sounds a lot.
Sounds like a lot? How long did it take me to produce 2 million sperm?
Okay. Not compared to the males.
Yeah, exactly. Not compared to the males. Heck, I've probably made 2 million sperm, more than 2 million sperm since the beginning of class today. So if you think about it, it doesn't sound like a lot of gametes to be producing. However, and so if you're not making a lot, the issue becomes genetic diversity, like we've talked about. One of the things with males is I'm releasing 500 million sperm per ejaculate. There's a tremendous amount of diversity there with all the ones that I'm making. But let's think about this. How many eggs typically does a female release in an ovulation? In an ovulation, a female typically releases 1 egg. Excellent. How many ovulations a year? On average, 12. How many years of ovulations of reproductive viability does a female have? 45, 50. Let's go with 50 because it's better math. 50, let's say 50 years, right? Again, if you think about it, that would mean from 13 to 63. So that's probably more than is actually likely for most women. But 50 is a nice round number. So in a total of her life, how many eggs is a female going to ovulate from her ovaries? Yeah, 600. And that's tops. So when you think about they're only starting with 2 million, clearly we still are having a massive amount of genetic diversity here, because 2 million is far, far more than she is ever, ever, ever possibly going to be able to use. All right. So again, when we talk differences between males and females, and of course, being the smart, sophisticated students that you are, when we have two similar processes like spermatogenesis and oogenesis, how many possible essay questions could you have? 3. What's the third?
Comparison.
Compare and contrast, absolutely. So, right, describe oogenesis, describe spermatogenesis, compare and contrast the two. Excellent. These oogonium that divide to produce new cells, they basically become primary oocytes. And they all become primary oocytes. What this means is at the time of birth, the female no longer has stem cells. So a female, when she is born with all of the eggs she is ever going to have for her entire life. Now, these primary oocytes, like primary spermatocytes, and remind me again, what process does primary spermatocytes undergo?
Meiosis.
And specifically meiosis
1.
1. Excellent. These primary oocytes in females start meiosis 1, but they freeze very early in the process. They freeze in basically prophase 1. And they stay in that state until puberty. So this process starts in utero, starts prior to birth, and then it stops. It freezes until puberty.
When it freezes, what age?
At birth. This is at birth. At birth, when these primary oocytes are made, they start the process of meiosis and they freeze in prophase 1. And they stay that way from birth until puberty. All right, so again, we know we have this, green's fine, I don't care. We have this oogonium. It undergoes mitosis, divides to produce 2 cells, and ultimately all of the cells that are produced become primary oocytes. And these primary oocytes freeze in prophase 1. All right. And again, till birth, from birth. Until puberty. At puberty, the primary oocyte finally is able to complete meiosis 1. So let's draw a line here as well. Now, when it completes meiosis 1, let's think about the things that we know from spermatogenesis. How many cells does it produce? How many divisions does it undergo? How many cells does it produce?
2 haploid cells.
I'm sorry, how many?
2 haploid cells.
Excellent, absolutely correct. And you answered the second part of what I was going to ask. What we get are 2 cells, and you are absolutely correct. We go from a cell that is diploid, 2N, 2 cells that are diploid, NR. And actually, I guess we should put that R there too. Our primary are 2NR. There we go. We're getting to that. Don't spoil the ending to my story. All right, so one cell becomes two cells at the completion of meiosis. And in the case of the sperm, these would both be secondary spermatocytes. However, as Alex has pointed out, with the completion of this, what happens is the cells divide unevenly. One cell just gets the genetic material. And that cell that just gets the DNA, as was mentioned, is our first polar body. The second cell gets half the DNA. And again, it's half the DNA. It's haploid now. I should have said half for the last one. Half the DNA. Plus, it gets all the cytoplasm. And this cell is our secondary oocyte. Why? Why not just divide it evenly like we do with the sperm? Yeah, why? But why not give both cells the DNA in the cytoplasm? Well, true. I mean, so again, both of them get half the DNA. So I should, so this one also half the DNA as well. So they're both getting, right? Because remember, meiosis 1 is where we split the tetrads. So this is getting half the DNA. The other one's getting half the DNA. So they both are getting the same amount of DNA. The difference is one is getting all the cytoplasm and one gets none of the cytoplasm. Is this one that gets none of the cytoplasm? Is that going to be a viable egg that can be fertilized and become a person? It's got half the DNA. Why can't it become a person? Why not? Yeah, exactly. Remember, all that sperm is a chromosome missile. All it provides is the genetic material. If that fertilized egg, and what do we call a fertilized egg again? A zygote. If that zygote's going to be able to divide to become 2 cells and divide to become 4 and divide to become 1,000,000, if that fertilized egg is going to be viable to be able to divide and become a person, it needs to have things like a Golgi apparatus and a rough endoplasmic reticulum and mitochondria and all of those types of things. And the sperm doesn't bring any of that stuff to the party. So if that egg is going to survive, if that fertilized cell is going to survive, it needs all those things. So rather than dividing those resources in the female, one cell gets all of it and one cell gets none of it. And that one cell that gets none of it basically is just genetic garbage. It's, that first polar body is a non-functional cell. But what we do have is a secondary oocyte that has the potential to have all the resources necessary to survive when fertilized. Now, of course, remember here we started and froze during meiosis 1. And the same thing happens to this secondary oocyte. Our secondary oocyte starts meiosis 2, and it gets a little farther this time, but it still doesn't get to finish it. It freezes during metaphase 2. So it starts and freezes. Hours. All right. And it is in this state, as a secondary oocyte, an immature cell frozen in metaphase 2, that the egg is released by ovulation. All right. Do we expel the sperm in males before they're mature? No, we mature them first for 20 days in the epididymis before we even think of releasing them into the ductus deferens. But here, this egg isn't even fully mature yet, and it is being released via ovulation in this immature state. And if the secondary oocyte is not fertilized, by a sperm, well, let's say it this way. If it is not fertilized by a sperm in 24 hours, it dies. Our secondary oocyte lasts about 24 hours. And if it is not fertilized in that 24-hour period of time, it dies, never having fully completed meiosis 2. It dies as an immature cell. Only if it is fertilized. By a sperm will it complete meiosis 2. So if and only if it is fertilized by a sperm, then it completes its meiosis, where of course it will divide into 2 cells. And again, do you think it's going to divide evenly or unevenly? So again, we have a second uneven division, where again, we get 1 cell that is just the chromosomes. And we call this the second polar body. And what remains is finally our mature ovum, which of course is the singular of an ova, which are the plural. Of course, this is N. But remember, it also has that sperm in it. Oops. Which also, remember, has N chromosomes that it brought from dad. And these 2 nuclei are going to come together to form a diploid cell that is our zygote. So notice you never get a mature ovum by itself. The only way you get a mature ovum is if it is fertilized by the sperm, in which case it's automatically going to become a zygote. So again, one cell gets chromosomes only. One cell gets DNA and all the cytoplasm. Now, I think you just are going to ask me the question that I was going to say. What happens to the first polar body?
Yes.
That is an excellent question. And the question is, do you think it is possible for the first polar body to divide? Yeah, it can divide. And when it divides, it is going to produce two polar bodies that will all have unreplicated haploid chromosomes in them. So it's possible to have as many as 3 secondary polar bodies. But really, do we care if that first polar body divides? Depending on the situation, sometimes it'll divide, sometimes it won't. This is a big fat maybe. But more importantly, it's a we don't care. Because whether it divides or doesn't divide doesn't change how many viable gametes we get at the end of the process. Unlike in spermatogenesis, where one stem cell gives us that one primary spermatocyte that gives us 4 sperm, here, one primary oocyte gives us how many mature gametes?
1.
How about 1? There you go.
Do they get recycled or like?
Yes. So as we will see, that DNA is going to be an important resource that can be used as building blocks, but it's not going to be a viable gamete. But yeah, like all the resources, yeah, we can recycle those resources and use them. And we'll definitely do that in this case. But the point is they're not becoming viable gametes. All right, I've done this here, but let's look at the picture from your textbook where it goes over this as well. So again, at puberty, we start our ovarian cycle. And again, does that ovarian cycle continue until 15 minutes after the female dies? No, it stops at a point we call menopause, where females become utterly useless from a reproductive standpoint. All right, and at menopause, the female is no longer able to produce viable gametes, and reproduction ends for her. All right. I just mean strictly from a biological standpoint. Women can do anything men can do except pee standing up. Well, you can pee standing up too. It's more messy for a female. But so the one thing women can't do is old women can't produce gametes and old men can. Other than that, they can do anything. All right. Excellent. So let's look through the pretty picture. Again, basic same steps, mitosis, meiosis. Oogenesis is similar to spermatogenesis, but the timing is very different. We still have a stem cell that undergoes mitosis and gives us primary oocytes. Those primary oocytes start meiosis 1. But again, they freeze at that point. And so at birth, all the mitosis is done. And like I said, the female is born with only about 2 million primary oocytes frozen in prophase 1. And does she keep all of them until puberty? What do you think? Do you think all 2 million survive 13 years until puberty begins? No, in fact, by the time she reaches puberty, she only has about 400,000 remaining. Again, it's a minuscule number compared to what males produce. But as we also talked about, in the most extreme situation, a female is using 600 oocytes during the course of her life. So 400,000 is still far more than she is going to need during the period of time that she is sexually viable. So we have plenty of genetic diversity, plenty of available resources for that process. At puberty, follicle stimulating hormone stimulates many of these oocytes to start the developmental process, causing the follicle to grow. We'll talk about the ovarian cycle in just a minute. And typically one completes the oocyte developmental process. That developmental process involves that uneven division. As we talked about, the cells divide unevenly, giving us a first polar body. Oh, let's go back. This first division, again, secondary oocyte and a first polar body. It then starts metaphase 2 and then freezes again. We get that secondary oocyte and first polar body. Starts meiosis 2 and freezes in metaphase 2. And it is in this immature, non-functional state that it is ovulated from the ovary. And it only gets to complete meiosis if it is fertilized by a sperm. If fertilized by a sperm, it completes meiosis, forming a mature ovum and a second polar body. That first polar body is capable of dividing. So technically, we still get 2 divisions, 4 cells, but only one of them is a viable gamete of those 4 cells that are produced. All right. Questions on this?
If first polar body is not useful, what's the point of division?
The point of the division is we still need to have the chromosomes. Remember, meiosis 1 is about going from a diploid cell to a haploid cell so that we can produce gametes that only have 23 chromosomes.
Okay.
So we still need the division so that we can separate the homologous chromosomes. So we can go from 2N to N.
Yes, thank you.
Yep. All right. Any other questions on this? All right. So humor me. We've talked about oogenesis. We have talked about spermatogenesis. Compare them for me. Tell me how they're different from each other. Remember, when you're doing these compare and contrast, often it is useful to help you to emphasize and focus your thinking to talk about the characteristic that you are comparing that the two on. So someone give me some examples. Okay, excellent. So one of the differences is a timing difference. Spermatogenesis is continuous from puberty to death, whereas is oogenesis a continuous process? No. In fact, it starts and stops twice, right? First, prior to birth, and then from puberty to menopause. Now, someone mentioned mitosis and meiosis of oogenesis. Doesn't spermatogenesis involve mitosis and meiosis? Okay, sure. Excellent. Okay, so I like that. Number of steps. Oogenesis has 2. Mitosis and meiosis, whereas spermatogenesis has 3. Mitosis, meiosis, and spermiogenesis. Notice this is kind of a nicer way than just saying spermatogenesis involves spermiogenesis and oogenesis doesn't, right? So this is kind of a better way to make that same comparison. Now, what do you mean by genetic variation differences? Ashley, what do you mean by that? Ashley, did you fall asleep mid-sentence? Someone help her out. What do you think she meant? Or give me something else. What do you mean by the maturation rates? I like that. Can you be more specific? Excellent. So sperm take 90 days from stem cell to mature sperm. 90 days. How long do they take in women to go from stem cell (28 days? 14 days? How many days?
From stem cell or from the birth?
From stem cell to mature egg, how long does it take? We want to compare apples to apples. 90 days for stem cell to mature sperm. How long from stem cell to mature egg? Okay, it can vary, but give me one number. What's the fastest it could be? There you go. That's what I like. Excellent. Remember, this starts in utero with the stem cells, and we don't even get the potential to mature the egg until puberty. So at least 13 plus years for that to occur. I guess if somebody wanted to tell me what 13 times 365 is, we can convert that into days. But absolutely, the maturation rates are absolutely positively dramatically different in the times there. Yeah, exactly. So again, continues after puberty. So it's got to be at least 13 years for that. Spectacular. What else? True. So you are correct. Size and movement are differences between the egg and the sperm. The egg is much, much larger. The sperm is much, much smaller. The sperm is motile. The egg is not motile. Those are definitely ways that we can compare the gametes, but that doesn't compare the processes of oogenesis and spermatogenesis. So you do want to be careful about that. That is absolutely a way that they're different. But right now we're talking about the processes. So how you make them. There you go. Excellent. Number of viable gametes from the process. All right. Again, here we go from one primary cell to one mature gamete. Here we go from one primary cell to 4 mature gametes. Excellent. And I'm sure there are a bunch more we could do as well, but you get the idea. These are the ways that we can compare. Okay, I like that. So, okay, here's a couple of things here. So let's go back. So now you guys are all, as I was getting ready to stop. Okay, excellent. So again, if we were thinking of the maturation process, you are right. The sperm mature in the epididymis. So that's where it completes meiosis 2 and matures into a, so let's even say that. You're right, it matures to become viable in the epididymis, but we can even do more than that, right? It basically completes meiosis in the testis. It completes it in the seminiferous tubule, right? Whereas the egg doesn't complete its maturation till after ovulation. And that maturation takes place in the uterine tube, right, or the oviduct, and only if it is fertilized by the sperm. So that's another thing you can think of as well, right? In this process, it is an independent process in spermatogenesis. Once these cells start dividing, you get sperm. Whereas in oogenesis, it is a dependent process. You only get to complete meiosis if it is fertilized by the sperm. So no sperm, no finishing the process. Yep. So, okay, I thought that that was where Ashley was going with the genetic variation as well. The genetic variation, a lot of that comes from the relative number of gametes that we make. Absolutely. And you're absolutely correct. Men basically make an infinite number of gametes during their process, or mature an infinite number, right? If you think about it, we can even go more extreme than that, right? If you think about it, a female only ovulates about 600 oocytes, but does every single one of those mature? No, if you think about it, they only mature if they get fertilized. So if you released 600 eggs and every single one of them got fertilized, you'd have 600 kids, right? And again, you have to carry that kid for 9 months, so the math would go way, way off on that. But yeah, you've absolutely got the right idea. Men produce billions upon billions of sperm, whereas females release, let's say it that way, can release billions upon billions of sperm, whereas females release very few, but still have plenty of genetic diversity. Looks, oh, wow, there's a bunch of comments. All right. Great question. So next question. I don't think we talked about it at the time, but I did mention an egg when released is viable for about 24 hours. A sperm is viable for about 48, although there are some, and this is not my term, this is their term, super sperm, that can last about 72 hours. So if you think about it, you have about a 4-day window of time where copulation has to take place, where there can be viable sperm and a viable egg together at the same time. So yeah, so the sperm only lasts for a short period of time in there, and that is about 48 to 72 hours at the most. So from about 3 days before ovulation to about a full day after ovulation, copulation has to occur during that time to get those kooky kids together, the sperm and the egg together, so that fertilization can occur. Yep, so again, one primary oocyte produces one ovum, one primary spermatocyte produces 4 spermatozoa, so we got that. Ah, there you go. Excellent. So meiosis gives us even division in spermatogenesis, uneven division in oogenesis. It's another great way that it's different. Perfect. True. Yeah, absolutely. Oogenesis takes place in the ovary, well, in the female, because again, the maturation, the completion of meiosis would actually occur after fertilization, which took place in the uterine tube. So the process occurs in the woman, whereas obviously you're right, the formation of mature sperm-shaped cells occurs solely in the testis. All right, excellent. Caught up with all the comments. You guys were saving them up. Excellent. That's awesome. All right, questions on that? Oh, there's another one. Health of the baby, no. My understanding is that the timing for fertilization doesn't affect the health of the baby. The one thing that may be related to it, and again, this is one of those mays like height. Most males are taller than most females, right? So if you take the average height on the planet, males, our average height is taller than females. Does that mean that every male is taller than every female? No, it's a spectrum. It's the same thing here as well. But in general, the male sperm tend to be slightly faster, and the female sperm tend to be a little bit longer lasting. So if copulation occurs right at the time of ovulation, there is a slightly increased likelihood of having a male offspring, because the faster X chromosome sperm Y chromosome sperm are more likely to get there and fertilize it. However, if copulation occurs further away from ovulation, then it's more likely that the Ys have died out and you tend to have a slightly higher percentage of X chromosome sperm left, and so slightly more likely to have a female baby. So it doesn't affect the health of the baby. It affects, but it may have a very small influence on the sex of the baby. Possibly, yeah, that's one way to think of it. So yeah, again, anytime you've ever seen this, and we'll talk about this process, but there is nothing more American than the fertilization of an egg, right? If you watch it on TV or the cartoons or other things like that, it's always about the first one there, right? That big go-getter, the fast swimmer, the one that gets there first, the one that wins the race, fertilizes the egg. As we'll see, and as we're going to talk about, the egg has all sorts of protections around it. And it takes hundreds of sperm to break through those protections. It's one of the reasons why males have to produce so many sperm, is because there's a tremendous attrition and they need enough to get there so that the first 200 that get there, use all their energy, all their resources to bust through the defenses, and then that slacker that took his time getting there finally strolls up after all the workers have done the work breaking down the walls, strolls in and fertilizes the egg. America, right? So there you go. Yeah, absolutely. So again, excellent. Questions on that? And again, we'll talk about development and fertilization in more depth next week. All right, we have talked about, where are we time-wise? We're doing good. Okay, we have talked about oogenesis. But remember, this developing egg isn't just hanging out in the ovary by itself. Remember, it has those support cells that are going to be helping it as well. And so while we talk, now that we know what's happening with the egg, we have to talk about what's happening in the follicle. And what's happening in the follicle is our ovarian cycle. So what we're going to do next is talk about our ovarian cycle. We'll go ahead and take a break first. It is 2:30 now, so let's come back at 2:45, and we will restart at 2:45, and I will start the recording at that point. All right, so any questions on oogenesis before we take our break and come back with the ovarian cycle? All right, see you in 15 minutes. All righty. Any questions before we get started? All right, I think our picture here from the textbook does a really nice job of showing us the process of the ovarian cycle and all the stages that are taking place of it. The one point that I want to emphasize, because again, I've been asked this question before, so I just want to nip it in the bud right now, is to emphasize that what they've done in this is show all the stages in one cycle, but the actual follicles do not move along the ovary. So it's not like they start up here at 11 o'clock and they rotate around and then ovulation occurs at 5 and then it continues to rotate around. What'll happen is, for instance, this particular follicle right here will go through all of these stages just at that location during one ovarian cycle. And then in the next ovarian cycle, maybe this one here undergoes all these stages. And then for the next cycle, maybe it's over in the other ovary, and so on and so forth. So these are indeed all of the stages, but it doesn't move within the ovary. All these occur with one follicle in one location. All right. So let's go through this process. Clear all of that, excellent. And work our way through. The ovarian follicle develops, the ovarian cycle basically develops in two main phases. The first is the follicular phase and the second is the luteal phase. Now, these phases, notice, are set on a 28-day cycle, because that is the average cycle. But does every female have exactly a 28-day cycle? No, right? So it can vary. Some can be as quick as 23, others could be as long as 35. But typically, once a female reaches sexual maturity, she is on a fairly stable cycle. So it may be for one person 28 days, but 1 month it may be 27, 1 month it may be 29. Someone else may be on a fairly stable 32-day cycle. Sometimes it'll be 31, sometimes it'll be 33. Typically, somebody won't 1 month be 23 and the next month be 35, though. So you typically don't get that type of undulations once the mature cycle is established. At the first onset of puberty, can a female have wild fluctuations in the timing of her cycles then? Yes, absolutely. In fact, she may actually skip menstruation for several months when it's establishing it. But once it's established, it stays fairly stable. And like I said, on average is about a 28-day cycle. Also, the differences in cycles primarily occur in the follicular phase. The luteal phase is much more standard and much more typically just about 14 days. So when you see variations in cycle, it's usually in the first part, the follicular cycle, and then the luteal phase is more stable. Also, we obviously need an event that is going to distinguish the follicular from the luteal phase. And what do you think that is the event that separates the follicular phase from the luteal phase? Exactly, Ovaltine. Ovulation is that phase. The events that occur prior to ovulation is the follicular phase, then ovulation occurs, and then we have the luteal phase. All right. Now, like your book's done it, again, we're going to divide this up into 8 steps through the development of the follicle. And again, I don't care about the steps so much as you understand all of the processes as they occur. Again, this is a more elaborate process, so let's again do this by talking about it, by drawing it ourselves. Let's look at the starting point. The starting point at the onset of puberty. What is the state of all the eggs? All of the eggs at the onset of puberty, how would you describe that egg? If on an exam I pointed an arrow at that and asked you to identify it and tell them to identify it specifically and to be as specific as you can, how would you identify all the eggs at the onset of puberty?
Phase 1.
Excellent. Perfect. We're getting there. Primary oocytes, which would get you partial credit, but is someone also been, what do you mean by phase 1?
I mean prophase 1.
Oh, okay, excellent. Frozen in prophase 1. Absolutely. So at this point, all of our eggs are primary oocytes frozen in prophase 1. All of them. And all of our eggs have a single layer of squamous cells, single layer of squamous cells wrapped around them. What type of cells did we call these?
Follicle cells.
Excellent. Follicle cells. And this structure, a single primary oocyte surrounded by a single layer of flat cells we call this a primordial follicle. So prior to puberty, all of our follicles are primordial follicles, and they're going to be clustered together in the cortex, not just randomly spread around. And guess what we call a cluster of eggs? Where do you find eggs out in the wild? In a nest, absolutely. They're all clustered together in a nest. So we have these primordial follicles clustered together in nests. Then what happens next is at puberty, we get an increase in our follicle stimulating hormone. This follicle stimulating hormone stimulates the follicular cells. And they mature into a single layer of cuboidal cells that we now call granulosa cells. So what we have now is that same egg. Oops, I don't like that. And I'll use abbreviation so it fits in here. This is still a primary oocyte frozen in prophase 1. That hasn't changed. But now our granulosa cells have started to mature. Yes, our follicle cells start to mature, and as they start to mature, they become a layer, and I'll cheat and draw it this way. a single layer of cuboidal cells. And these single layer of cuboidal cells, though, are now granulosa cells. The follicular cells have become granulosa cells. And granulosa cells can produce estrogens. Now, of course, remember, to make estrogens, we have to start having the formation of thecal cells that form on the outer surface. So some thecal cells will start to form. And this structure that we form right here is what we call a primary follicle. All right. You with me so far? So prior to puberty, all we have in the ovary are primordial follicles. But once we start our ovarian cycle, then an increase in follicle stimulating hormone causes those follicular cells to mature into granulosa cells, and we start producing estrogens. And when we have a single layer of granulosa cells, we now have a primary follicle. Now, here's where that whole 28-day cycle thing goes out the window. Literally dozens of cells each eat dozens and dozens of primordial follicles start this process each month. And the process of getting from primordial follicle to primary follicle can take up to a year. So this process of getting from primordial to primary follicle is a slow process. But each month at the onset of the month, we have a dozen or so that get to this primary follicle state. These follicles, so now we have many of these, continue to mature. And by continuing to mature, I mean they're follicles. Continue to mature. What'll happen is our egg gets larger. It is growing. It is starting the maturation process, but it is still a primary oocyte. In prophase 1. That hasn't changed. But what has changed is what's going on around it. For starters, how do I want to draw this? I'll use black because it amuses me to do so. A glycogen-rich outer layer shell forms on the outer surface of this. This glycogen-rich, literally candy-coated shell on the outer surface is what is known as the Zona Pellucidum. Are one layer of granulosa cells becomes 2 or more layers of granulosa cells. So we have 2 or more layers of granular cells. Around that primary oocyte, frozen in prophase 1. And at this stage, we now call it a secondary follicle. Oh, and of course, let's not forget our thecal cell layer. Oops, nope. Thecal cell layer on the outer surface as well. Now, while many start this process, at this point, only a small number reach this stage each month. And at this point, the race is on. You either win, and if you win, you get ovulated. If you don't win, if you lose, then basically you're broken down and reabsorbed by the ovary. So of these secondary follicles that form, only one reaches the mature state, what we call a mature follicle, what we call a tertiary, because after all, if we have a primary, we have a secondary, we have a tertiary follicle, or what is also known as a Graafian follicle. Now, one more thing starts to happen to these secondary follicles. The growth of the follicle starts to outpace the growth of the egg. And so what starts to happen is we get this massive expansion of this follicle, and small spaces will start to form where the cells start to move away from each other and start to open up small spaces. Eventually, these small spaces fuse together to form a large, open, fluid-filled antrum. So we're going to have to change the scale of our drawing here a bit. Here is our egg. And again, our egg has continued to grow in size, but I'm having to make this smaller so that it fits. We still need our Zona Pellucida around the outside. And this is our follicle. And just for scale, let's say that's the size of one cell. So you can see how thousands of cells are forming this large follicle. So what we have here is and let's go ahead and fill it in with the highlighter just to emphasize that this is all cells. And again, we have this huge fluid-filled antrum that has formed here in this mature follicle. But there are two other big changes that have taken place as well. The first, oh, and of course we got to put our thecal cells on the outside. Can't forget those. Those don't go away. But there are two other big changes that have taken place. The first, whoa, that's huge, involves the egg. In this tertiary state, whoops. Come back. Here in the tertiary state, finally, the egg completes meiosis 1 and divides unevenly to produce a secondary oocyte. And again, of course, that secondary oocyte starts meiosis 2, but freezes in metaphase 2. The other big difference is a vocabulary thing. As we know, anatomists love to give names to things. Notice this cell that we drew right there is a granulosa cell. Well, guess what? We also have a granulosa cell right here as well. If I were to pluck those two granulosa cells off of this follicle, put them under a microscope and look at them under the microscope, would they be the same or would they be different?
Same?
They would be the same. They would be identical. They're identical cells with identical functions. The only difference is their location. But as we know, do anatomists like to give things names based on their locations? Yeah. The granulosa cells that directly surround the egg are called, because it's kind of a crown around it, corona radiata. So we have that corona radiata around the egg, around its zona pellucidum. And it is from this mature follicle that ovulation occurs. When that ovulation occurs, our secondary oocyte frozen in metaphase 2 plus the corona radiata that surrounds it are expulsed. What that means is that the remaining granulosa cells stay behind. All right. With me so far? So it is as an immature secondary oocyte frozen in metaphase 2 that our egg is ovulated out of the ovary, and we hope it gets into the uterine tube. Is it guaranteed to get in there? No, but we hope it's getting in there. All right, are you with me so far? All right, then let's talk some more, starting here with the beginning of this process. If you think about it, this process began because we were making follicle stimulating hormone. All right? That caused these cells to start to produce estrogens. And that estrogen caused this to mature, caused this to grow. From this secondary follicle, we have a race where only one cell wins and gets ovulated, and the rest basically end up losing and getting broken down. And remind me again, what hormone is responsible for ovulation? We get a massive spike of what hormone that triggers ovulation? Which one? Luteinizing hormone or follicle stimulating hormone? Someone break the tie. I'll wait. Luteinizing hormone, excellent. There's a massive spike of luteinizing hormone, and that luteinizing hormone triggers ovulation. But that massive spike of luteinizing hormone triggers something else. Luteinizing hormone, as the name would indicate, luteinizes something. What luteinizing hormone does is it transforms the remaining follicular cells into a massive glandular structure. And that massive glandular structure is called the corpus luteum. So that ruptured follicle that is left undergoes this massive transformation. First, it looks like this popped balloon, but then the cells start to enlarge and they start to swell and they start to expand. And in some cases, the whole thing could swell together into this big, huge, massive glandular structure called the corpus luteum. And as we talked about, this corpus luteum produces what hormones? What hormones or classes of hormones are produced by the corpus luteum? Estrogens. That's not surprising, seeing as the follicular cells did that. But does our corpus luteum produce anything else? Progestins, excellent. It produces estrogens and progestins. Massive amounts of estrogen and progestins. And remember, progestin is that warning bell that tells the uterus and the female body to get ready. The egg has been released. Fertilization could occur any minute now. We could be getting pregnant as we speak. Get the body ready. Now, what happens in time is that the amount of luteinizing hormone decreases. And as luteinizing hormone decreases, we cannot maintain the corpus luteum. And so the corpus luteum starts to shrink. It shrivels up until it shrivels up and becomes a tiny piece of non-functional scar tissue. And that piece of non-functional scar tissue we call the corpus albicans. At that point, it is just a little shriveled up piece of scar tissue that can't produce glands anymore. And once that corpus luteum is gone and our corpus albicans forms, then our cycle starts again. So these are our 6, and then I'll show you the 7th when we go work our way through it. Stages that we have talked about for our ovarian cycle. Let's go through the pictures from the textbook, because that way we can talk about a couple more things while we go through it. Let's go through it a second time, and then I'll ask our questions. So, again, we start prior to puberty. We start basically at birth with a cell like this one right here. This cell right here is our primary oocyte, frozen in prophase 1, surrounded by a single layer of squamous cells. So this is a primordial follicle, and another primordial follicle, and another primordial follicle, and another primordial follicle, and another primordial follicle. All these primordial follicles are all nestled together in their nest. And this is how every single follicle begins. However, with the production of follicle stimulating hormone, some of these start to mature. And if you'll notice, one of these things absolutely positively does not look like the other. Notice right here, we see an egg, a little bit larger than the other ones, but it's still a primary oocyte frozen in prophase 1. But notice here, we have a single layer of cuboidal cells around it. So while we have a half dozen primordial follicles here, what do we have here inside of the circle? A primary follicle, absolutely. Here we see another really nice example of our primary follicle. And again, as we talked about, this slow development of many of our primordial follicles can take over a year to get to the primary state. So at any one time, a female may have dozens of these primordial follicles that are slowly maturing towards the primary state. But once they reach this primary state, they now have mature granulosa cells around them. Notice we start to see the very beginning of the formation of that dark line, which is the Zona Pellucidum, that glycogen-rich layer. Notice we see the very beginning of our thecal cells starting to form on the outer surface. And those thecal cells make the androgens that the granulosa cells use to make estrogens. So here we get the formation, start making small amounts of estrogen. Now, questions on that? Estrogen, as we know, causes the maturation of the egg and the follicle. Well, of the egg primarily. Let's start with this. But estrogen does something else interesting as well. Estrogen has a very complicated relationship with the anterior pituitary. Low levels of estrogen cause the anterior pituitary to stop releasing follicle stimulating hormone and luteinizing hormone. So they stop releasing them. Notice I didn't say stop making them. The anterior pituitary still makes luteinizing hormone and follicle stimulating hormone, but does not release it. All right.
You say with low levels of estrogen.
Yes, low levels of estrogen cause this. Now, as our follicle continues to grow, our follicles, plural, continue to grow, remember we mentioned a few of them reach the secondary state. And again, you have more granulosa cells, so you make more estrogen. And if you make more estrogen, you suppress the anterior pituitary even more. So even less follicle stimulating hormone is released. This starts to be an issue because remember, follicle stimulating hormone is what stimulates the follicle cells. And if follicle stimulating hormone drops, what happens to our follicle cells? Less cells can survive. There is less follicle stimulating hormone for the follicles. Remember, as we mentioned, at this secondary follicle rate, we have this race. If and only if you can get enough follicle stimulating hormone or is sensitive enough to survive with small numbers, then will it survive? All other follicles die. So remember, once we reach this secondary follicle state, the race is on. You have to get enough follicle stimulating hormone. You have to be sensitive enough to follicle stimulating hormone. Well, only a little bit is enough to keep you growing. If you can't get enough follicle stimulating hormone to keep you going, then that follicle dies. And so of the handful that start the secondary follicle stage, only one reaches maturity. So small handful. Notice 2 or more layers of granulosa cells. Only a few make it to that point and the rest degenerate. Now notice, as we talked about, these follicular cells start to outgrow the pace of the egg. Our egg's gotten much bigger. It's still a primary oocyte frozen in prophase 1. but it's much, much bigger. Notice we can much more clearly see the Zona Pellucidum, much more clearly see the thecal layer. But notice small gaps are starting to form in the follicle. Cells start to separate from each other. This is why your book says 7 stages, because it differentiates the late secondary follicle from an early secondary follicle. If it has gaps, it's late. If it doesn't have gaps, it is early. But I don't care if you make that distinction. And numerous gaps will start to form. I don't care if this has 75 gaps, it is still a secondary follicle. It is only when all those gaps come together to form one big singular fluid-filled space that we have our tertiary follicle, or what we call a mature follicle, or what we call a Graafian follicle. Notice at this state, finally, our oocyte has completed meiosis. This usually occurs about day 10 to day 14. We have the big, huge fluid-filled antrum that is formed. We now have the formation of our corona radiata. We can clearly see the zona pellucida and all those things. And again, now we have our secondary oocyte frozen in metaphase 2. This antrum continues to expand, getting bigger and bigger and bigger and bigger. Our follicle keeps getting bigger and bigger and bigger and bigger. And as I mentioned, the more granulosa cells you have, the more estrogen you have. And remember, I said estrogen has a complicated relationship with the anterior pituitary. Once estrogen reaches a critical amount, it changes its relationship with the anterior pituitary. Remember, the anterior pituitary has been storing up massive amounts of follicle stimulating hormone and luteinizing hormone that it hasn't been able to release. Well, when estrogen levels get high enough, it triggers the release of that massive spike of luteinizing hormone and also follicle stimulating hormone. But we emphasize luteinizing hormone because that massive spike of luteinizing hormone triggers ovulation. Here in this picture, we actually see the follicle bulging out from the side of the ovary. There's the secondary oocyte frozen in prophase 2, surrounded by its corona radiata, and it ruptures and it bursts, releasing itself from the ovary into the peritoneal cavity, into the peritoneal fluid. And hopefully that uterine tube is able to draw it into the uterine tube where it will hopefully get fertilized. This is the end of our follicular phase, but we're not done with our uterine cycle. Because while that luteinizing hormone triggers ovulation, the other thing it triggers is the transformation of the remaining granulosa cells into our corpus luteum. Notice, as I mentioned, when it first forms, again, it looks like a ruptured balloon that has popped, because that's essentially what it did. But it gets transformed into this massive glandular structure called the corpus luteum. A big, huge glandular structure, an endocrine structure that produces estrogens and progestins, telling the body ovulation has occurred, get ready for fertilization. Right? The body gets prepared for pregnancy. But if fertilization doesn't occur, luteinizing hormone levels drop. And as luteinizing hormone levels drop, our corpus luteum shrivels up into the corpus albicans. Takes about 2 weeks, at which point we just have this non-functional scar tissue, a little bit of fibrous connective tissue that is no longer glandular, called the corpus albicans. Obviously, we're no longer producing estrogen and progestins. So without the estrogen and progestins, no more inhibition. We can start producing follicle stimulating hormone again. And with new follicle stimulating hormone, a new cycle begins. Unless fertilization occurs, and that, of course, disrupts this process, but we'll talk about that later. Questions on this? All right. The last thing, this is all I wanted to do from a lecture standpoint for today. And this is where we'll pick up on Thursday. But I still want to do some histology. I want to finish the male histology and start the female histology. So we will take one more break. We will restart at 3:45. I'll start the recording at that point. And at that point, we will do our histology that we've seen. Yeah, I can switch to the picture for this. Do the histology from this, and then we'll go from there. And that'll be all we have to do today. All right. Any other questions? There you go. All right. I will see you at 3:45. We had already talked some in the past about the histology, starting with one of the structures we looked at, which was this one here. What was this structure again? Identify the organ in the field of view. Seminiferous tubules, excellent. Right, in the testis, perfect, absolutely. Right, and again, one of the ways we were able to identify that is by the cells at their different stages of division, right? Our spermatogonium, primary spermatocytes, secondary spermatocytes, early spermatids, late spermatids. We can see the flagellum and all of that. One of the tricks to the histology of the male is that, remember, this is where we produce the sperm, and this is where we mature them. What's the organ where we mature the sperm again?
Epididymis.
In the epididymis, excellent. At first, this may appear like the exact same organ. In fact, it kind of looks like flagellum sticking out from the edge of it here, so it could be challenging to distinguish them. However, what type of tissue did we say we found in the epididymis? Excellent. A ciliated pseudostratified columnar epithelial tissue. Now, there was something special about this ciliated pseudostratified columnar epithelial tissue. What was it?
Non-motile.
Non-motile. So those cilia don't move. They're just there for surface area. But as you look closely, we see what appears to be multiple layers of nuclei, although we know they're just irregular shaped cells. And again, we clearly see the cilia sticking out. So the key way to tell these apart is twofold. While it looks like multiple layers of cells, notice you don't see any nuclei really towards the apical surface. Whereas in the seminiferous tubules, you'll see a large number of nuclei here. The other trick to recognizing this is understanding the processing. Remember, in the epididymis, we're using primarily fluid pressures to move the non-motile sperm where we want them to go. There's a lot of fluid in these tubes. Now, to process this tissue, we have to first freeze the tissue. We then take a very sharp blade and slice off a piece of it. We then put it into all sorts of staining types of solutions and then slap them on a slide. Those staining solutions are typically very dehydrating. So when this tissue dehydrates and that fluid goes away, one of the characteristics that makes you easily able to recognize the epididymis is the clumping of the sperm together in the center. It's very, very stereotypical that this will happen. You always see this clumping of the sperm in the center of an epididymis, whereas you don't see that in the seminiferous tubules.
Is there a reason why?
It's strictly because of the processing. When you dehydrate this tissue, all that water goes away, and so all of the sperm clump together.
Okay, thanks.
So based on that, what is this? Epididymis or seminiferous tubules?
Epididymis.
This is the epididymis, right? Again, these are not spermatogonium or primary spermatocytes or anything. Very few nuclei near the apical surface, big clump of sperm at the middle. So as long as you are careful and look at it, at first glance, you may think seminiferous tubules, but spend a little time with it. Make sure you look for those key things and you'll be able to easily distinguish them. All right. The last little bit of histology, actually I lied. There's two things we need to know left for this. The first is the easy one, sperm. Or again, we want to use the appropriate terms on the exam, spermatozoa being the plural, spermatozoon being the singular. As we know, it has three distinct regions. What's that region there?
Head.
What's that region there? Mid-piece. What's that region there? Flagellum, excellent. Or the tail, right? Those would be fine as well. And again, remember, this is also the genetic region. This is the motor region, and this is the locomotion region. So we have those as well, those regions. But notice also, if you look closely, and do I have another picture? I remember if I have another picture. Yeah, I do have another picture. Notice with a little bit more light and a little bit more contrast, one of the things we consistently see is the very tip of the sperm is much, much lighter in color. Why is that? What is that specific structure right at the tip of the head on these? Acrosomial cap. Acrosomial cap, absolutely. That is the acrosomial cap that we can see clearly at the top of that. All right. And again, that's pretty much all we need to know for the sperm. There's not a whole lot about them. They're just basically a chromosomal missile. The last histological thing we need to be able to identify is the penis. Notice the easiest thing to recognize is the urethra, because we've seen that before. We know even at a low magnification, this is going to be lined with a transitional epithelium. We can see those many invaginations for it, a thick lamina propria that has a lot of glands in it. But notice we also have that corpus spongiosum, that erectile tissue around the outer surface of it. And outside of that, we have that tunica Albigenium, that is going to be that fibrous outer layer. Notice here we have the Tunica Albigenium, that fibrous collagenous skeleton that contains the erectile tissue. So as that erectile tissue expands, it pushes against that fibrous skeleton, giving it its rigidity. I think we have another one here. Excellent. Notice here, again, we see that a spongy tissue of the Corpus Spongiosum, Corpus Cavernosum. And notice while its placement isn't the greatest, because often you can see them better in the middle, but we can also very clearly see that structure right there. Any idea what that might be?
The deep artery.
Yeah, the deep artery. This is what is going to be feeding the blood into this erectile tissue. And again, we have that fibrous Tunica Albigenia surrounding the structures, and then also forming a little bit of a midline septum. Again, this one doesn't show it as nicely as the previous one. We see the Corpus albicans around the Corpus Spongiosum. Pardon me, the Tunica albicans much better around the Corpus Spongiosum. But we have that for the penis. And one more. This one I have because I really, really like. Here you can really clearly see the nice, big, thick, muscular walls of those deep arteries. Here you can really nicely see that Tunica albicans around the outer surface of those two big, large erectile tissue, corpora cavernosa, and then the urethra surrounded by the Corpus Spongiosum. And another deep artery for it as well.
What are the structures on the bottom on each side?
This, it looks like muscle. So my guess is some kind of muscle. Could be part of the cremaster muscle, maybe, coming down, depending. I'm not quite sure of the plane of section of where this is, but that tissue definitely looks like skeletal muscle tissue. So it could be part of the pubic symphysis, right? If we're close to the base, it could be something like that. It could be part of the cremaster muscle surrounding the spermatocord as it's coming up next to the penis. It's hard to tell from where exactly we are in this plane of section, but I would say it looks like skeletal muscle. All righty. That is the boys. And then, of course, again, an up close look at that Corpus Spongiosum around the urethra for the male. All right. Let's talk about the ovary, because this is a good lead into the things that we were just talking about. One of the things that we've got here is a cat's ovary. And one of the things they do to these cats to prepare them prior is they inject them with a massive amount of follicle stimulating hormone. Notice if you inject them with a massive amount of follicle stimulating hormone, there's no competition. All the follicles are getting all the follicle stimulating hormone they need, and we can get a large number of mature follicles. And so that's what they have done here. Now, notice if this is a mature follicle, then where's the egg? Is this really a mature follicle? What do you think? If you guys aren't interested in the histology, I'm happy to call it a day.
You mean this is the largest one?
Well, it is large, but if it's a mature follicle, then why don't I see an egg?
Because its ovulation occurred already?
Not a bad guess, but no, not because ovulation has occurred. Why don't we see an egg? And also not a bad guess. Those are all good guesses, but no, let's think it this way. Is it possible to cut an apple and not see the core?
Yes.
Yeah. Just because you don't see the cord doesn't mean that it doesn't have one. It just means that that one plane of section where you cut that structure doesn't have everything you're looking for. These are big, huge, massive follicles that have a tiny little egg in it. And so it's possible that when they cut it on the plane of section, it didn't have the egg in this plane. In fact, if you look, most of the follicles, you don't see the egg. Here we see a nice one. There we see a nice egg right there on this follicle. But notice most of them don't, but it's just because of the plane of section. Now, this one I've just highlighted. Identify that egg, that cell, be specific.
Mature follicle?
The cell. Identify the cell, not the follicle. Identify the cell. And you get partial credit for that on the exam. But you're missing. The secondary oocyte. Anyone? What's she missing? There we go. Frozen. Closer. Be even more specific. There we go. Frozen in metaphase 2. Excellent, excellent. But you are correct. If instead I had drawn a circle around this whole thing and asked you to identify this entire structure, then yes, you would say that this is a mature follicle or a Graafian follicle or a tertiary follicle. I know this is a low magnification, but identify this entire structure. Secondary follicle, excellent. Identify the cell at the center of it. Be specific. There we go. Primary oocyte, frozen in prophase 1. Perfect. Identify this region here. Excellent. And then this region out here. Cortex. And one more. Identify this structure.
Corpus Luteum?
Yeah, that's the beginning of our corpus luteum. Again, notice ovulation just occurred and the cells are getting dark because it is starting to be transformed into that corpus luteum. So this is the beginning of the formation of the corpus luteum. Notice we can see a lot of these things on this particular one. Here's actually a cat ovary. Some more examples, another one. But let's look at some more precise examples. Identify this entire structure. Does the green not show up well enough? Identify this entire structure.
Primary oocyte?
No, but the entire structure. Identify this entire structure. Not the cell, I want to know this entire structure. Again, remember, as I've often said on exams, people lose points, not because they don't know the information, but because they don't read the questions carefully.
Primordial follicle?
Primordial follicle, excellent. But you are correct. If instead my arrow pointed here and I asked you to identify the cell, what cell would that be?
Primary oocyte.
And you get partial credit for that. There you go.
In prophase 1.
There you go, frozen in prophase 1. Excellent. Notice there's a cluster of these together. What would we call a cluster of these together?
Nest.
Nest, excellent. But notice this one, oops, no, I don't want an arrow. I want a circle. Notice one of these things is not like the others. What started to happen to this one here?
It becomes the primary follicle.
Yeah, our squamous cells are starting to bulk up and be cuboidal, forming indeed a primary follicle. All right. So again, here we have some primordial follicles. Here we have another example of a primary follicle starting to form here. Not the best example, but it does a good job of showing it. And then notice here, so we go from there to there to there.
Secondary follicle.
Okay, this one's primordial, this one's primary, this one's secondary. Notice our egg has gotten much, much bigger. But is it the same as these other two, or is it different from these other two? If on the exam, I pointed my arrow here and said, identify this cell, be specific, what's your answer? Guarantee these are going to be questions on the exam. Identify this cell.
Primary oocyte.
Finish it.
Frozen in phase 1.
Yeah, frozen in prophase 1, absolutely. All three of these, if all three of these, I point to the egg at the center, all three of these are primary oocytes frozen in prophase 1. The cell's getting bigger, the cell's maturing, but it still hasn't completed meiosis 1 yet. All right. Notice, go ahead.
So if it's frozen in metaphase 1, it's already the one that's going to leave the ovary, right?
Metaphase 2.
Oh,
Not metaphase 1, metaphase 2 if it's going to be ovulated. All right. Notice here we still have a secondary follicle, multiple layers of granulosa cells. We can start to see some spaces starting to form. And again, notice we see this glycogen-rich acellular layer on its outer surface. What was that called again? Zona Pellucidum, excellent. And we can also see the beginning of the thecal cells that are forming on the outer surface of it as well. And there's a good look at that Zona Pellucidum. Again, here we have that fluid-filled space forming, right? But is this a tertiary follicle? Not yet, no, exactly. It may just be one space, but notice the space is about the same size as the egg. That's not going to cut it for a tertiary. To get to the tertiary, right here, multiple stages, multiple spaces, still secondary. Nice primary one that we see here, some primordial ones, more secondary. Again, there's lots of spaces that will start to form, but it isn't until it forms one big, massive antrum, one big, massive space, that it is now a tertiary follicle. Notice very clearly, we can see, wow, that's huge. That clear layer right there, what's that? Identify that structure.
Zona Pellucidum.
Excellent. Identify this structure here. Corona radiata, excellent. Identify the space.
Antrum.
Identify the cell, be specific.
Primary oocyte frozen prophase 1.
Is it still?
Oh, no.
Once we get to the graphene mature stage, it is now a secondary oocyte frozen in metaphase 2.
Oh, yeah.
And it is as a secondary oocyte frozen as metaphase 2 that it will be ovulated. Here's another example of a tertiary and another example of a tertiary. All right. And then, like I said, once ovulation occurs, it ruptures and we get this, what first appears to be kind of a deflated balloon shape as that corpus luteum starts to form. But notice it can become a big, huge, massive glandular structure. That corpus luteum basically fills this space, becoming a massive glandular structure, producing estrogens and progestins. Here's another example of a big, huge corpus luteum. But eventually, it goes from this big, dark, stained, massive glandular structure to this tiny, shriveled up, typically very pale looking structures that are the corpus albicans. If you were to slice an ovary open like this and look at it, you can kind of count the number of corpus albicans in there, and it'll give you a sense of how many ovulations have occurred. It can give you, so if you just randomly find an ovary on the side of the road, you can look for scars on the outer surface from the rupturing of the ovulations. You can look at corpus albicans on the inside, and you could get the relative age of that ovary by getting an indication of how many ovulations, how many corpus albicans are present. I think that's the last one, but let me see. Yep, that was it. All right, we have some more histology in females to cover, but we haven't gotten to the anatomy of it yet, so worry about the histology of that later. All righty. Questions on that?
What was the function of the corpus albicans, or like not the corpus albicans, but the one before?
Well,
like the
again,
puffy part.
The corpus luteum produces estrogen and progestin.
Mm-hmm.
So when it's forming and when it's fully formed, it is producing and releasing massive amounts of progestin and massive amounts of estrogens. However, it starts to shrink. And as it shrinks, it produces less and less estrogen. And when it shrivels up into that corpus albicans, it doesn't produce any hormones anymore.
So if the egg got fertilized and became a zygote, what would happen then?
Something different. I want to finish talking about, we went over it briefly, but I want to go over it again in more detail. The complex hormonal regulation of the ovarian cycle. Once we do that and see how it normally functions, then we can talk about how we change and modify that with pregnancy to maintain high levels of estrogen and progestin. But we need to, I want to go over it again. I know I mentioned it. I know we talked about it as we went through it, but I know it's also a lot of material. So I want to, we focused on the ovarian follicles. I want to focus on hormonal regulation next when we come back on Thursday. And then we'll talk about how you modify that process with pregnancy. So we will get there, I promise.
Okay, thank you.
All right. Great question. Any others? All right. That is all I have for today. Study hard. What do you guys have to do on Thursday? Your Labster. And remember, last daily quiz. Be there or be square. All right. Have a good day. I will see you guys on Thursday. Take care. Be safe and see you in 2 days.